Hello, everyone. I'm Jamie Lira, Vice President of Marketing at Clinical Architecture. Welcome to Beyond Good Enough. Today, we will talk about what it means to cultivate an ecosystem of high-quality, trustworthy data, from how we collect and manage our own institutional data to how we receive and effectively integrate exchange data, and why setting that foundation of usable, high-quality data is necessary for improving patient outcomes, AI initiatives, analytics, and performance measures. Feel free to submit questions using the questions box in the upper right-hand corner of your screen. We'll have about 10 to 15 minutes at the end of the presentation to address your questions. Our speaker today is Charlie Harp, CEO of Clinical Architecture. Charlie has over 35 years of experience as a healthcare software engineer and systems architect. His work focuses on improving data quality and usability, which led to the creation of the Patient Information Quality Improvement, or PIQI, framework, a practical methodology for assessing and improving electronic health data. Charlie serves as the co-chair for the PIQI Alliance and chair of the AMIA Industry Partnership Council, roles that reflect his commitment to advancing the field. Charlie also hosts the InfoMonster podcast, where he explores a range of healthcare IT topics, including interoperability, data quality, and emerging trends in healthcare data management. Over to you, Charlie.
Thanks, Jamie. You almost make me sound like a respectable member of the community. Hi, everybody. I'm Charlie Harp. I'm CEO and founder of Clinical Architecture, as Jamie said. And today we're going to talk about data quality with a focus on why the landscape is changing in healthcare around data quality. And we're also going to share kind of some key findings from our 2026 data quality survey. So let's get started. So the first thing to think about, or the question I want to try to answer, is why is healthcare data quality important? And a lot of you might be thinking, well, Charlie, of course we know why it's important, but I want to create kind of a metaphor for why now it's important and more important than maybe it has been in the past. So go with me on a journey, if you will, into this idea of the evolution of our healthcare ecosystem. And I like metaphors, I like analogies, and so I want to use a metaphor like biology, cellular life. In the beginning of healthcare, every single place where healthcare was practiced electronically was like its own little individual data silo. It had data, it had functionality, and its real focus was its ability to support its use case, its purpose, and everything worked just fine. And then what happened was we started to realize that we could connect with each other in healthcare. And this is kind of when I started working in healthcare, doing things with, for example, reference labs. You send out data and they send back results, whether that's by fax, by auto dial printer, or by email. The idea was we started to do connections with each other, but it was focused data exchange. So it was very obvious if the data wasn't right because the data didn't work for its function, like exchanging lab results between two systems. And so we evolved mechanisms like HL7v2 to be able to do these point-to-point transactional interchanges of data. And then you come to kind of where we are today, where instead of just doing focused transactional data exchange, we're starting to share data for general healthcare exchange purposes. Oh, you want to know about Charlie Harp? Well, I know a thing or two about Charlie Harp. Here you go. And so right now, today, we exchange that data, whether it's through HIEs or whether it's through FHIR or whether it's direct. And for the most part, the way we use that data today is still for a human being to look at the data. It gets serialized into some kind of output. A human being looks at it. But the goal of what we're trying to get to in healthcare is this idea of we want to be able to derive insights. We want to be able to leverage tools like analytics and artificial intelligence. And what we really want to be is in a place where we have fully interoperable healthcare. We always have a complete and good picture of what's going on with the patient, so that regardless of who's seeing the patient at any point in time, we all benefit from the knowledge that's produced by that exchange. The problem we have is today in healthcare, the data quality is not really fit for that purpose. The data is still very siloed, and we don't have the shared semantic across our silos. And so we still exchange data that is not mapped, so it's not directly usable, or it's poorly mapped. We have issues where the data has errors because the thing that I'm using the data for that you sent me may not be why you created the data, or you might have created data incorrectly in your environment. You might have merged patients incorrectly in your environment. We don't always know where the data comes from. Provenance is still a big issue in healthcare, and we also share things in a way that's not necessarily compatible. The running joke that if you've seen one CCD, you've seen one CCD, and the hope is that that type of philosophy doesn't transcend into FHIR, but we're humans, we do that kind of thing. And so the concern is, if we have this data that we're trying to share, and there's all these qualitative issues, and then we start to use AI and other technology to accelerate and proliferate and use that data, the concern that I have, and I think a lot of people have, is that what's going to end up happening is not this beautiful utopian patient record, but something different, a corrupted healthcare ecosystem. And for those of you who aren't completely in tune with my imagery, I'm saying this would be bad. So the question is, how do we avoid this? Well, the way we avoid this is by taking things that are currently in flight, standardizing on the FHIR messaging syntax and the IGs, so that we have a common way of packaging up, canonically aligning and sharing information, using things like the patient information quality improvement framework to make sure that we understand, can measure and understand the actual quality of what's in the FHIR payload. Things like TEFCA and QHINs, HIEs, HDUs, to really manage the physical movement and trust of data and provenance of data across the ecosystem. And things like digital quality measures that utilize this data downstream and help us to identify where things could be better, both from a data perspective and a practice perspective. Because if we do that, then there's a chance, there's a decent chance that we can create this fully interoperable ecosystem and leverage tools like AI and old school analytics, and even benefit human providers that are trying to make decisions based upon the data that they're given and presented with. So that's my metaphor. But let's also talk about the pragmatic reality of healthcare. And this is something that I've personally struggled with over the last 35, 37, maybe 38 years I've been doing this. And that is this guy. Being in the business of data quality, one of the things we're confronted with all the time is that the quality of the data is good enough. The data is good enough. Why do we need to do a bunch of work to improve the quality of data, to map things, to normalize things, to manage things? The data is good enough. But in reality, those of us that work with the data, that look at the data, realize the data is not good enough, and maybe things aren't actually on fire. But so the question is, why do some people feel like the data is good enough? Why do they seem to be okay with less than high quality usable data? And I came to a realization that I've been struggling with this whole idea of the data being good enough. And what I realized is, well, from their perspective, the data was good enough. And let's talk about that. So why has the data been good enough up until now? Well, the first thing is healthcare has become culturally accustomed to fragmented systems. It's kind of like we realize that's the way it is, and it is the way it is. That saying that I don't love, which it is what it is. We've become accustomed to that being the way it is, and we just deal with it. The next thing is the operational success, the financial success of an organization is more important than perceived data quality concerns. And people don't always connect the dots. They don't always see, unless you're in the weeds of the data, you don't always realize how good data can can improve performance over bad data. I always use the analogy of, driving down the highway at 70 miles an hour with a windshield, covered in mud. You wouldn't want to do that. Well, operating your enterprise without good visibility on what the data can tell you is in my opinion, similar to that. Workflows function despite uncertainty in patient information. And this is because of the next point, which is humans compensate for data quality gaps manually using unstructured data, knowledge, and experience. So the thing that really protected us for the last, several decades is that human beings look at the data and say, I know that's wrong. I'm going to make the right decision and ignore the things that I know are wrong. And part of the struggle we're dealing with right now is twofold. One is the number of humans that have experience is shrinking. The number of patients that have complex situations is growing. The amount of data we have that has to be potentially reviewed or ignored is expanding. Healthcare data doubles, I think, every 73 days is the last number I saw. And so what we've got is more complicated patients, more data, more types of data, fewer people that have long experience dealing with this. And we just can't keep up anymore. And now we're starting to deploy technology like artificial intelligence, generative AI specifically, against the data. And it is not going to have the experience and the understanding to ignore the data that it thinks is wrong, because it's just going to assume that what you give it, what you prompt it with, what you've trained it on is the truth. And so humans aren't going to be able to continue to do that. Corporate incentives focused on growth, compliance, and revenue, not necessarily the quality of the data, because once again, humans compensated for where the data fell through. And legacy reporting and analytics also tolerated inconsistent data. In fact, a lot of the use cases we have for data are in the rearview mirror. There are things like quality measures, which tell you how you've done. When you start thinking about putting more data and more decision in front of the patient at the point of care, the quality of the data becomes much more important, because you're not looking at things through a historical lens. You're really trying to be more proactive. And if you're going to be proactive, you require better data. And the other reason why the data has been good enough is because it's difficult to fix the data. Having a quality data environment is a lifestyle choice, not a project. And with all the other tactical priorities of a healthcare system, it's not easy to carve out the time necessary to focus on data quality. So why is the perspective changing today? And I talked about this a little bit on the last slide, but part of it is that people are starting to realize forward-thinking organizations are operationalizing data quality, and they're starting to see benefits from that, whether it's operational efficiency, whether it's improved quality measures, improved metrics. They're starting to realize that if they can optimize and understand what's happening with their data, they can leverage that as an asset that they can use to make better decisions. And that's been a trend we've seen with our clients, and I'm sure others have seen that trend as well. The bar for data quality is continually raised, and for data sharing is continually raised at a regulatory level, both in the US and other regions. And so the need to share data and share that in a standard way increases the need to make sure that data is quality and you're doing all the right things. And in my opinion, there's a lot of information in the news right now about information blocking, and I would argue that exchanging poor quality data is unintentional information blocking, because whether you don't give it to me or you give it to me and I can't use it, the net result is the same. So that is driving the need for people to have better quality data that's usable out of the gate. When you start looking at things like digital quality measures, and you go from having a curated set of data being reviewed for digital quality to theoretically all your data being used for digital quality measures, or any other type of digital transformation, if you don't have good data quality, you're not going to have trust, and you're not going to really know whether the results you're seeing from those analytics are actually real or not. And I could talk for hours on that. I'm not gonna do that to you guys. And now, as we start looking at using AI, it's very obvious that AI on poor quality data is artificial stupidity, and we can't. That's not tenable in healthcare. It will impact not just patient safety, but it'll impact your cost and your operational efficiency, and it'll undermine the trust in those tools that people are currently investing a lot of money in to try to take advantage of what AI, generative AI, and other AI approaches are capable of. So quality is getting a huge tailwind by all the AI initiatives that are happening across healthcare. I also talked about this idea of quality measures. You start to see results that are very obviously wrong when you start to do things at scale with poor quality data. And of course, the clinicians who are trying to use that data, who want the complete picture of the data so they can make good choices, it's not a viable solution to present them with 1,800 pages of printed or PDF clinical data for the last 20 years of the patient's life. You really need to start having ways to take the data, improve its quality, and leverage that uplifted data in a way where you can synthesize a current state so that you're providing the provider with a current picture of what's relevant about that patient. And you can't do that if you've got a bunch of inconsistent, semantically incompatible data. All you can do with that is print it out and put it in front of somebody, which does not help with clinician burnout. And we're also at a point where we are sharing data with broader ecosystems. So whereas in the past, we were doing that point-to-point transaction, and we could focus on just making sure the quality of that data was good enough. Moving forward, we have the opportunity, if we have good data quality, to not just share that data for things like quality measures, but to also share that data for purposes like public health, to share that data for benefits administration, to share that data for different population, for research, for pharmaceutical development. So there's a lot of potential for that data if we can just focus on improving the quality and provenance of that data. And then, of course, the financial impact of that bad data quality is becoming easier to quantify as we start to kind of dial in and look at the alignment between facility resources, clinical cohorts, and the things that drive value-based care and improve patient outcomes. So with all of that, now I'm going to go ahead and share with you guys the results of our 2026 data quality survey. So for the last 4 years, Clinical Architecture has done a survey where we asked kind of the same set of questions to folks across the healthcare ecosystem about data quality specifically. And so what I'm going to do now, and you can certainly, I think somebody's dropped into the chat the link to the data quality survey, and you're welcome to review the complete data quality survey. But what I'm going to do now is I'm going to go through some key findings in the survey and talk about kind of what it means and what the trends are. So the survey itself, we had a number of respondents across these verticals: care provider, academia, consultant, public health, value-based care, EHR vendor, analytics vendor, and life sciences. And as you know, a lot of the data we have in healthcare is produced by care providers. There's a lot of people that support that process, and of course, a lot of people that consume and disseminate that data. And so the idea here is we try to ask the same questions to get the perspectives of each facet of the ecosystem and what they thought about data quality, to see if we could see differences or similarities. The first big takeaway from this survey, and it's not super different from the previous year's survey, is that most people feel, not surprisingly, that poor data quality has a moderate to high impact on the things they're trying to do in healthcare. And the categories we use are performance measures, the effective use of technology, work efficiency, public health reporting, care quality, financial impact, and patient satisfaction. Now, all of these indicate that that every one of these categories was either moderate or high impact, and 76% said that it was high impact, 23% moderate, and 1%, I don't know who this guy was, said no impact on these things. And this is important because when we talk about impact, AI was not on the survey specifically, but obviously AI is heavily dependent on data. It learns from it, it's prompted by it, and so the impact of poor quality data is not only significant where it is with things like quality measures or providing care, but whereas those things are deterministic and the process by which it's making decisions is hardwired by the algorithm. AI, its logic, its processing is also influenced by the data. So it makes for a very impactful experience on AI if the data quality is bad, both in terms of prompting and training. So this is not a surprise. The idea that poor data quality has high impact on the things we're trying to do, this shouldn't surprise anybody. The next thing is, the first question is, does bad data impact what you're doing? The answer is yes. The second question is, so how's your data? This question, the summary of this question is 74%, up from 68% last year, which probably means that more people are actually looking at their data, feel that the data is mixed quality, which means in some domains it's good, in some domains it's not as good. And if you look at the breakdown by data domain, you can see that, demographics being mixed is the highest, social determinants of health being the worst at 0.73, where 1 is mixed, 0 is poor, 2 is high. You can see that most of these things fall on the low side of mixed, and things like procedures, diagnoses, medications, lab results. In general, people are saying the data is not great. And of course, EHR vendors and public health both reduced their self-rating roughly 30% versus 2025. And that was a pretty significant shift for them in terms of how they felt about the quality of the data. The next question is, why? Why do you think the data is bad? And what's stopping you from making the data good? The number one factor was time. Data quality, improving the quality of the data is non-trivial. And people said, listen, it's challenging for us to put in the time to improve the quality of the data. The second one was lack of interoperability, meaning when I get the data, I have to do work to that, which kind of goes back to the first item. The next one is most of the data is unstructured free text and notes. Most of the useful data that I need is not structured. And the next one is it's hard to get it out of the software. And then the other is data entry errors, which tied with software, which says that people are not entering the data correctly and trailing at the very end, whereas people that felt like it was because there were too many code systems and things that required alignment. So those were what the reasons that were cited for why it was challenging. And the next thing is interesting is this idea of external data. In the report, we asked a question about external data, and the question was, what do you think about the quality of external data, and what's your intent around bringing that data in? And so the first thing is, most people felt like the data from other places is not good. In fact, when you compare how they rated their own data versus how they rated other people's data, almost universally people said that my data is not great, but their data is worse. And so there's obviously this trust issue where people are looking at the data coming from somewhere else and they feel like that data is not great. Now, because of people are being driven to share data, when asked whether or not you're thinking about integrating data, some of them said we're already integrating data, and others said that they're going to be integrating data at some point in the future. Only a very small number of people said I have no intent of integrating data from someone else. In fact, if you look at the bars below, the integrate to intent, the bars, it's interesting that the EHR vendor that participated in the survey had the lowest intent of integrating someone else's data. And the truth is, it's understandable, because taking data from an outside source and integrating it into an EHR platform is actually more challenging than a lot of people may realize. And so because of semantic issues, because of canonical issues, taking data from somewhere else and putting it into your longitudinal record and being able to say, hey, this came from somewhere else, and have provenance for that is not a simple thing to do in an EMR or EHR platform. So that doesn't surprise me, but it might surprise some. The other thing too is, and we didn't ask this question and maybe we should have, which is, what do you mean by integrate? Because I think some people, when they talk about they're already doing it, I think they mean that they're putting it into a place where people can see it, where humans can see it. The real question is, are you actually integrating that data into a place where technology can see it, where AI can see it, where analytics can see it, where clinical decision support can see it? And so that's probably something we should consider adding in the future, to talk about what do you mean by integrate when you say integrate data that's external. The next question is, what are your concerns about getting data from somewhere else? And the interesting thing is, the number one concern about getting data in from elsewhere is that I don't trust the accuracy and quality of that data, was their single largest issue. Semantic interoperability and mapping was secondary to this general quality concerns. And it's probably obvious to most people on this webinar that when you get data from somewhere else, it's a project. It's very rare that we get data, whether it's through an HIE or a QHIN, that we get data that we are ready to just drop right in and use. There's usually work you have to do, and that's kind of this effort of semantic interoperability is a big part of that. Even if the data is good quality, it could still be semantically interoperable. And if that's a situation, you have to do work. The next thing is, there's just too much data. One of the challenges with interoperability is I share data with you, you share data with me, you share my data that I shared with you with them, which gets shared back with me. It's very easy to create a cascading tsunami of information that can just be overwhelming and confusing for providers that are trying to figure out what the heck's going on with the patient. And so, it contributes to provider fatigue, which is already an issue for a group of individuals that are experiencing significant time famine. The last thing they need is a huge amount of additional data that they have to sift through. The effort for creating interfaces for message formats was the next one. And that's really this idea that, with all the variability in CCDs and V2 messages, but that didn't seem to be a primary concern. And part of that could be that people are optimistic that FHIR will alleviate that, or they already have solutions in place that deal with that. And then the last was the direct cost. For me, spending money for data, that did not seem to be something that people were as concerned about as just, if I get it, is it going to be good enough for me to use? So, and there are some things that changed year over year that are notable, like that people are more concerned about provider fatigue, because as data sharing becomes more of a reality, it's kind of like be careful what you wish for, you might get it scenario where, oh, now I'm getting all this information and it's overwhelming. And so that's something I think as we evolve as an ecosystem, as we continue to embrace TEFCA and information exchange, one of the things that are gonna bite us, I think, is gonna be how provenance actually works in the ecosystem, how much duplication we're going to experience, how much semantic interoperability is going to be a struggle, and this idea of controlling who is sharing what. Because if we're all sharing all the data that we get from everywhere, it's going to definitely be overwhelming. And those are things that once we start really interoperating, I need more coffee, and sharing data, we're going to see, we're going to discover these things that we're not experiencing today, because today we're truly not interoperating. So that's something we're going to be seeing. We also asked about message formats, and so we asked, of these message formats, what are you currently implementing? What do you have no plan to implement? Now, we didn't have a huge number of life science respondents in the survey. So, and that's really where OMOP is prevalent. So we didn't see a lot of people saying, I'm excited about OMOP. We didn't have a huge number of payers in the survey. So the concept of X12, but it could also be that these are formats that are slowly being eclipsed by FHIR. As FHIR gets more adoption and has more use cases, that could also be that we're seeing a shift, which is a good thing, I think, because FHIR is a good canonical standard for a lot of these things in healthcare. CCDA, there's still a lot of interest and work happening with CCDA, but there's also a lot of people that, once again, are shifting towards FHIR. FHIR is increasing in its adoption, and the people that plan to do it. The people that have no plan to implement FHIR, we could probably dig into that a little bit more, but I see that FHIR will continue to increase as its use cases expand, and HL7 is massively implemented, because it is, whereas FHIR is a good way to exchange pictures of a patient for particular use cases. HL7v2 is still kind of the ecosystem for meaningful transactional exchange. And as you can see, there are still people planning to implement that going forward. And I expect that both CCDA and HL7 will be around for the better part of the next decade, if not longer. Even though FHIR, I think, is going to continue to increase in adoption. One of the things we introduced this year was a question about the Patient Information Quality Improvement Framework. For those of you that may not be aware of what PICI is, it is an open standard based framework that Clinical Architecture originally introduced about 2 years ago. We decided to make it an open source framework, and we've established with Levitt Partners and others the PICI Alliance, which has over 150 organizations participating, where together we establish shared rubrics for scoring patient data quality based upon a use case. So for example, right now we have a clinical data model, and in that clinical data model, we just rolled out a USCDI version 3.1 aligned rubric that allows people to score data as to whether it is meeting the bar of quality for USCDI 3.1. We've also started to roll out claims-based rubrics that align with the Care and Blue Button initiative, so that for Care and Blue Button based exchange of claims data, you can determine whether the data is quality. And we've also been talking to folks in public health and Social Security. We've been talking to folks both in the US and in other countries about establishing PICI. And what makes PICI different than classic measurement is, rather than measuring data in a silo, it allows you to measure data based upon a shared objective understanding of what quality is. So when you say my data is quality, well, what is the score and what does it actually look like? What we did in this survey is just ask people, are you aware of it? And there was pretty much a 50-50 split of respondents who were aware of it and respondents who weren't. And one of the things I wanted to go into just a little bit, because I am, being the founding father of PICI, one of the things that I think is really important about PICI and why it's relevant when we talk about data quality right now is, before PICI, data quality was a subjective thing. People would do it against a schema. They would look at it through a particular lens. Well, when I create a rubric like the US CDI 3.1 aligned rubric, this is actual data. It's not a real facility, but it's actual data. I can look at what is the score, the overall quality score for the data I'm exchanging based upon the expectation of a use case. What are the data class scores for each data class? So for example, here I can see my overall score is 53%, but if I look at the data here, I can see that my conditions are 92%, my immunizations are 86%, but my procedures are 23%. So this gives me an idea of where my data quality is in terms of clinical data across those domains. And then with PICI, it looks at the reasons why data quality fails. And so, for example, for lab results, I can see specifically where do I need to improve to make my data usable, so that the people that are consuming this data, whether it's me or whether it's someone else, can have confidence in the data that I'm bringing to the table. So that's just kind of a nutshell. If you want to learn more about PICI, just go to piciframework.org, and there's all kinds of information there. And we would love to have your involvement and your voice as part of the PICI Alliance. And it's currently going through HL7 ballot. So if you're an HL7 member, check it out and give us your feedback. So for the data quality report, the bottom line is, and this is kind of what we try to suss out, do we realize that there's a problem, or is there a problem? And one of the things that the survey indicates is there is definitely a problem, and we realize the problem is there. The next question is, do we know what the impact of the problem is? Do we know what the stakes are? And, according to the survey, people say, yeah, we realize that data quality is an issue, and the issue has impact on us as an industry and our ability to be successful. We understand what the causes are. The causes are time, interoperability, and just the effort that we have to put in to fix the problem is a challenge. And so we need tools, we need resources to do it. And the other thing too is trust. I've always said, and I think this might have been coined by someone here at CA, Laura Bush. She said that, trust is the last barrier to interoperability. And there is a trust problem in healthcare. And some of that we can fix by improving the quality of the data. Some of that can be us having more knowledge about where the data came from, so that we can understand whether we feel that source is credible or not. And so these things together are really good indicators of where we are as an industry. The most important thing that we need to really focus on, I think, as we go into the next 3 to 5 years, is that if we try to deploy artificial intelligence and digital quality measures and other things against the data we have today without understanding what the quality of that data is, we're going to get results that are going to probably scare us in terms of undermining our faith in these technologies. But there's nothing wrong with the technology. It's the data underneath the technology that we really need to focus on. And we're going to have to roll up our sleeves and do the hard work of improving that data. The nice thing about it is, initially, it's going to be a challenge for most organizations to lift the quality. And then once it's lifted, you can't just treat it like a project and you brush off your hands and say, boy, I'm glad that's done. We as an industry really need to make data quality a habitual part of what we do every single day. It needs to be a lifestyle choice, because if it becomes a lifestyle choice, once it becomes habit, the amount of effort it's going to require will dramatically reduce, because we're not going to have to do a big chunk of work every now and then. We just have to do a little bit of work every day. And we have to also think about how we aggregate, how we curate, how we clean up that data, and not just keep chucking data into a clinical data repository without periodically going in and making sure that the data makes sense and the data is high quality. The data is not going to improve itself sitting there in a data warehouse on its own. We're going to have to put the work in to make the data incrementally better every single day. That's my mantra. That's my position upon which to evangelize. And I really hope that the industry moves in that direction so that we can have better outcomes and we can leverage technology the way we should. That's the presentation. Now I'll open up the floor to questions. If anybody out there has a question.
And we've also included the link to the 2026 data quality report in the chat. So if you'd like your early peek at it, go ahead and click on that link. And we'll give another moment or so for questions.
Questions, challenges, thoughts, feedbacks, ideas? All right.
Okay.
Then I'll give you guys some time back. Thank you so much for being part of the webinar. And please do check out the data quality survey. And please get involved in the PICI Alliance if you're interested. The more voices, the more perspectives, the better. And if you'd like to reach out to us at Clinical Architecture to learn more about PICI, Pixel Gateway, or any of the other things that we can do to help improve your data quality, please do. Thank you so much.